From the JAMA Network, this is JAMA Psychiatry Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Psychiatry.
Welcome to the JAMA Psychiatry Author Interview Podcast. I'm your host and web editor, Dr. John Torous. Today we're thrilled to be discussing a new paper just out in JAMA Psychiatry, Acupuncture for Combat-Related Posttraumatic Stress Disorder, PTSD, a randomized clinical trial. We're about to be joined by the corresponding author of the paper, Dr. Michael Hollifield, MD, from the VA Medical Center in Long Beach, California. PTSD remains a common and often chronic condition that impacts not only members of the armed services, but civilians as well. On this podcast, we have discussed different medications and psychotherapies for managing PTSD, but not other forms of treatment like acupuncture. Can acupuncture actually help, and what does the evidence show when we examine its effects in the most rigorous research conditions that feature both clinical as well as biological endpoints? To find out, we're going to explore the results of this new study just out in JAMA Psychiatry and discuss with the senior author, Dr. Hollifield. So thank you so much for joining us, Dr. Hollifield. And to jump right in, acupuncture is one of those loaded words where people have a lot of different preconceived notions of what it is. So let's start out by clearing the air. What is acupuncture and what is it not?
Thank you, Dr. Torous, and thank you, JAMA Psychiatry, for having us. That's a great first question. So acupuncture is the placing of solid needles into specific places or points on a body, far more commonly as a set of needles in a rational pattern to address a pattern of illness. It is not the use of needles to inject a substance. It is an intervention modality among many developed in traditional Chinese medicine. It is not the totality of a Chinese medicine approach. And it is either conducted manually or with electric stimulation. It is not used for trigger point release, though one can use this modality to treat specific pain areas which may assist in trigger point release.
And let's talk about details. In this study, you explore a specific type of acupuncture called Verum acupuncture. What is this and what makes it unique or different from other types?
Well, now we know what acupuncture is. Verum is from the Latin and is also from Icelandic and Old Norse. Think veritable, veritas, and you'll know what that means, truth.
Yes.
So actually the noun form is the truth and the adjective form is true. It now generally means we're doing real acupuncture according to a healing tradition and protocol, not just placing needles willy-nilly.
Got it. So verum, like veritas, truth. So we're doing true acupuncture. And we'll return more to acupuncture in a minute. But of course, this is a study about PTSD, post-traumatic stress disorder. We'll call it PTSD throughout the podcast. And in the paper, you note that there's a lifetime prevalence of nearly 7% in community samples and up to 30% in specific populations. People are always interested in complementary and integrative therapies. What is the evidence before you did this study, say, for acupuncture and PTSD?
The traditional Chinese did not separate mind and body, and this has been going on in their tradition for 3,000 years, so it's really questionable about what is original and what is complementary medicine, right? They did develop treatments for what we now call psychiatric disorders in the West, but they were not thought of this way. Even as one studied in philosophy and theology, I've never aligned with the dualism in the West and almost didn't pursue my dream of being a physician due to this mechanistic and reductionistic issue. I did a soul-searching trip as an early adult, and I met with Elmer Green, the father of biofeedback, for a few minutes. At the end, he shared with me that I should go to medical school because my kooky, holistic ideas would not be respected otherwise. So during the first study, we showed equivalence to a group cognitive behavioral therapy and superiority to a weightless control. Our Chinese collaborators also thought it was funny that we were developing this protocol for a mental disorder, quote unquote. They opined, we've been treating PTSD forever, but we just didn't call it that. I want to acknowledge Nitya Sinclair Leon for her courage on this study and IMH for funding that initial study. And then finally, after our first publication in 2007, Chuck Engel and his group published a similar finding in Medical Care in 2014 showing benefit against usual care. Subsequent studies have generally shown efficacy of acupuncture for PTSD, yet there's been a lot of limitations in the methods. The potential value of acupuncture lies in its effects in multiple and interacting body systems that are core to PTSD physiology. The current study essentially is a third clinical trial in PTSD, and the first we know of using a sham control and evaluating a biological outcome alongside a clinical outcome.
In many fields, there's high-quality research. There's research that's not always as high quality. But it sounds like to overcome some of those limitations, you and your team are trying to be as rigorous as possible with adding a sham control. What does a sham control mean in acupuncture?
Yeah, great question, because that is an essential question and challenge. The primary limitations have been not having the sham control in studies, certainly in PTSD and other psychiatric disorders. They haven't been adequately powered and assessed both clinical and biological outcomes or monitor protocol adherence. So sham procedures continue to be, again, the greatest challenge because they're not fully inactive. That's the problem when you look at sham acupuncture controls. There's currently 3 types of them. One is insertion with manipulation at non-acupoints. One is superficial insertion absent further manipulation at verum acupoints. And there's non-insertive needles that use a blunt tip telescoping mechanism to retract without puncture. But both insertive and non-insertive procedures probably influence expectation, sensation, contextualization, and both have shown effects in brain, actually, controlling sensation, cognition, and affect. So we decided to do a 4th type, which is minimal acupuncture, which is very superficial insertion off acupuncture points that are not expected to be active for PTSD.
That's an exciting way to approach this. Let's talk about your main hypothesis as well as the primary and secondary endpoints, because as you hinted at, you guys have both clinical and biological endpoints.
Primary hypothesis was clinical. We got to know whether or not verum acupuncture would reduce PTSD symptom severity and whether it would be large and significantly better than sham needling, even though sham is not fully inert. That primary endpoint was PTSD severity using the CAPS-5, the gold standard interview in PTSD. The secondary hypothesis was that acupuncture would be associated with larger pre to post-treatment fear-potentiated startle change than sham during both the acquisition and extinction of fear conditioning. And the important thing about this is that biology lies less than subjective experience, which is how symptom severity is assessed. Furthermore, since we can't blind the treaters from group assignment, looking at biological response sort of controls for bias to some degree, and the field trusts biological measures more than subjective responses, even though that's how we diagnose and follow PTSD. Finally, psychiatry continues to look for one or more of a set of biomarkers that can be used to reliably predict the validity of an illness or a treatment response.
That's a very clear answer, and it's, again, interesting to see, as you said, both the biological endpoints, even if we're treating the clinical. And for those of you not as familiar with PTSD work, the CAPS-5 is the clinician-administered PTSD scale that you can look up and read about more in the paper. Back to, again, your exciting research, Dr. Hollifield, to assess this hypothesis that the verum acupuncture would work better in the sham and you would see this evidence of the biological endpoints. You recruited, of course, a sample of people with PTSD. How did you recruit people, or who was going to be in this study?
Yeah, in this case, the sample frame was veterans with PTSD acquired from being in a combat zone. This group tends to be a little more wary and mistrustful of medication, pharmacotherapy, and psychotherapy. So we opined that if acupuncture is found to be useful for PTSD, the broadening of options for this group would be an advance in who we can reach. After all, approximately 75% of veterans with PTSD, they don't go to receive care for it at the VA. We can't say they're not receiving care anywhere, but we know that information. So we recruited internally at the Long Beach VA, though we could take referrals from those not registered if they came to us through word of mouth.
For those people who may not know as much about acupuncture, is this a one-time treatment? Does it happen over many weeks? I guess I'm asking, how is the treatment in the sham delivered and who is doing it?
This almost jumps to a later potential question, which is, what is the right dose of acupuncture, or what is the right dose of anything, right? And we don't know. And so our preliminary study was delivering it twice a week for 12 weeks. So we held to that protocol, and both acupuncture and sham were delivered twice a week for up to 15 weeks in order to get 24 sessions in. Each session is 40 minutes. After you get on the table and get off the table, it's about an hour. 3 licensed acupuncturists were on the study over a 4-year period and were trained to deliver the procedure, including the non-specific parts, which were the same for both groups. And lastly, in this case, we followed the protocol that we developed in our first study in a very rigorous way, which is doing first on the back and then the front and changing it over each session with 11 points on the front and 14 points on the back.
That's a rigorous method, and also people can get a lot of treatment. That can be many sessions if they want it.
They can, and it gave us the opportunity to look at, and we have not yet put that in this current paper, but is there a dose relationship, which we hope to look at later.
You explained you're recruiting veterans mainly from the Long Beach VA, but of course you take referrals. Who ended up joining and staying in the study? Let's talk about the sample.
Yeah, interesting. And this is for researchers, but also, clinicians and other interested parties alike. It's really hard to get these done because you get a lot of interest, but you got to touch a lot of people to complete the study. We touched over 600 people and introduced them to the study. We consented 165. We randomized 93, and then 71 completed interventions. So that's how that kind of goes. We had both males and females in the study, adults age 18 to 55, and had a good sample of women in this study, which we're really happy to have.
And I think, Dr. Hollifield, you've helped us understand what is acupuncture, how the study is going to work, who the population is. So perhaps the question that everyone wants to know the answer to is your primary endpoint was PTSD severity, as we said, measured with the CAPS-5. What did you all find?
The big news, eh? Well, I want to acknowledge Dr. Anfu Shao, who was our co-investigator, and our whole team here and the support of the VA Office of Research and Development to make it happen. Basically, what we found is that it worked. That is, Verum acupuncture was better than sham acupuncture. At the end of treatment, at the end of the 15-week period, the difference between the two groups was 7.1 points on the CAPS, which was a moderate effect size, and a clinically significant effect size. It's on that edge. Some people say a change of 10 is really clinically significant, but it depends on where you start. And then from pre to post, the acupuncture alone group did very well with a fairly large reduction, with a effect size of over 1, a Cohen's d of over 1, and reducing from 37 to 22, whereas the sham group only went down to a score of 29. So that's where we get a difference in the overall effects.
Those are definitely very impressive results. I mean, in part, perhaps why you're sharing them with us here on the JAMA Psychiatry podcast. But you have a little bit more to share because you had these interesting secondary endpoints around fear, startle, and the biological outcomes. What did you guys find there?
Well, we've talked about that a little bit, and this was a nervous and risky component, although our colleagues, Tanya Jovanovic and Seth Norholm, they've led this component, and they're world-class experts in psychophysiology and in trauma psychophysiology. So we were able to complete this psychophysiologic paradigm pre and post on 63 of those 71 patients, and 54 had a complete sample. And what we found was, number one, conditioning fear was successful at both before and after treatment, meaning that the paradigm is working to condition fear with a startle response as we expect to. And it didn't change with intervention. So we expect that too, that you can still condition to fear the same way with this paradigm. And what we did find that while fear potentiated startle during extinction at pretreatment was equivalent between group, there was a significant between group difference in fear potentiated startle during extinction at the post-treatment phase. That is, after treatment, people could condition their fear the same between acupuncture and sham, but the extinction, or when you don't provide the stimulus that makes people startle and you extinguish that startle response, those that were treated with acupuncture extinguished that startle response at a much higher and faster rate than those that had sham.
It really makes one think about some interesting mechanisms that you may be targeting with this. But for the sake of time, we won't go into all the mechanisms. Are there Any other results? I know when people read the paper, you make it very clear, you share a lot. Is there anything else you'd want to share with listeners now about other results?
Yeah, just to say that one thing we like about acupuncture, and I've been doing this for years, a medical acupuncturist and a physician, is that people take to it very well and have been asking for it. Our study retention rates were high, basically 91% for those that had acupuncture and had at least one treatment session, and 84% in those a sham group. And satisfaction was high on a questionnaire about were you satisfied, not satisfied, very satisfied, and it was very high for 98% of the participants. So these data continue to beg the question, how do people with PTSD heal? And what we want to share is that this theory that overt exposure to traumatic material in order to work through, process, or desensitize is kind of challenged with this study. And I've always believed that, and there's good data about this, initial trauma is first somatically experienced with rapid secondary emotional and then cognitive response. And it's largely been believed that we have to intervene on the accessible cognitions or emotions. Perhaps it's not completely true. Perhaps it's possible to alter somatic responses, which reduce danger signals and align those with emotional and cognitive responses accordingly.
That is a fascinating approach to it that also offers a lot more ways for people to access care and treatment. For clinicians listening and hearing your results and learning more about this, how would you want those clinicians to think about recommending or suggesting acupuncture to patients, about referring it and helping people get the right type?
Yeah, well, we now think with the body of evidence for acupuncture, it's certainly reasonable to refer people with PTSD for acupuncture, with the caveat that this protocol ought to be used. We would align these data with the fact that adherence to protocol and evidence-based psychotherapies provides better outcomes than when the protocol is altered. So until there's further research about what forms or what types of acupuncture might be useful, we would suggest, here's the study, here's what's been shown helpful in 2 studies now, and it'd be worth trying, and you should get this kind of treatment if you're going to get it.
And for people listening who may know someone with PTSD, may have PTSD themselves, how would you want them to use your study to inform the type of care that they seek for themselves?
I would say, look, the good news is options are expanding. Be informed about the cause of your symptoms, the possible interventions for them, and reach out to people knowledgeable about care options. Acupuncture is now reasonable to try. It may not work for you. It didn't work for some, as in all treatments, but it's certainly a rational way to go if you think it might be useful.
And one last rapid fire question. What do you see, Dr. Hollifield, as an expert in this area? What comes next for PTSD or your line of work in acupuncture and PTSD?
The obvious next step is comparative effectiveness studies. Acupuncture with other evidence-based therapies. We also need to learn more about where acupuncture might best fit in a trajectory of treatments and whether it is a best first treatment to help resolve the rapid stress response, or whether it's best to provide this in conjunction with other interventions. And then finally, we do need to know more about the mechanisms, and you had alluded to that, and that's a longer story. It's really courageous for people to lay on a table after trauma and let someone touch them and put needles in them. The specific effects and the non-specific effects are probably additive. We're going to need to learn more about these combined effects. And for gosh sakes, what does this mean about how we should prevent PTSD also?
It sounds like you and your team will be busy for some time to come with this impressive work, and hopefully more that we can read and learn from. That's all the time we have, so I want to thank again our guest, Dr. Hollifield, and thank you for tuning in. This episode was produced by Shelley Steffens at JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.